Okay, picture this. You see someone's skin, maybe their legs, their arms, and it's got this weird kind of web-like purplish reddish blue pattern, almost like a net or lace. And it definitely seems worse when they're cold. Have you seen that? I mean, maybe read about it while revising for something like the MSRA.
Yes. That distinctive pattern, it's got a name, and it's definitely more than just how the skin looks. It's called Livedo reticularis.
Livedo reticularis, right.
And you're spot on. Recognizing it is, well, it's pretty important in clinical practice, and yeah, definitely something that could pop up in exams.
Exactly. So today, we're doing a deep dive into Livedo reticularis. We're kind of working from a set of revision notes, boiling them down, making them really high yield for your studies.
That's the plan. We want to break this condition down into those key points you need for revision. Turn the core facts into a clear overview, highlight what's really important, especially for exam questions.
Good.
Because focusing on one thing like this lets us really build up a structured understanding what it is, why it happens, what else it could be, and, crucially, what you do about it.
Yeah, I'm keen to get into this because it sounds like one of those things that seems simple, just a skin pattern, but it could actually be pointing towards something, well, something bigger going on.
Absolutely. That's exactly why it's a good revision topic. The skin, it's often like a window,
Uh-huh.
and Livedo reticularis is a perfect example. The key is understanding the why. Why is that pattern there? What could be causing it?
Okay, let's unpack it then, starting right at the beginning. What is Livedo reticularis? How would you describe that look?
Okay, so at its heart, it's a description, a visual finding. It's that mottled, net-like pattern on the skin.
Right, the net.
Yeah, the color is typically purplish or maybe reddish blue, and you usually see it on the limbs, arms, legs. It really does look like a sort of lacy network under the skin.
And why? What's actually happening in the skin to make it look like that, like a net?
It's all about blood flow. Specifically, in the tiny blood vessels of the skin, the arterioles and the venules.
Okay.
Think of them like a network of tiny branching pipes. With Livedo reticularis, the little arteries, the arterioles, they constrict, they narrow down.
Wow.
And that narrowing disrupts the normal flow. Blood flow gets sluggish in those areas where the pipes are narrower, and it tends to pool a bit or slow down in the connected venules.
So the blood's not moving smoothly.
Exactly, it's sluggish. And because it's moving slower, more oxygen gets pulled out of the blood in those areas.
Right.
And deoxygenated blood looks, well, purplish or bluish. So that deoxygenated blood shows through the skin where those arterioles are constricted, creating that net pattern. The paler bits in between are where the flow is, relatively better.
That pipe analogy helps. Some pipes narrowed, flow slows down, and the cold makes it worse because, well, cold makes blood vessels constrict anyway.
Precisely. Cold triggers vasoconstriction naturally to save heat. In Livedo reticularis, that tendency is already there or exaggerated, so the cold just makes the pattern stand out much more.
Okay.
And this leads us to something absolutely fundamental you need to grasp. Livedo reticularis can be primary or secondary.
Primary versus secondary, that's the big split.
That's the crucial distinction, yes.
Yeah.
Primary Livedo reticularis is when you see the pattern, but even after checking, you can't find any underlying medical reason for it. It's often just there. Benign sometimes runs in families.
Okay.
Secondary Livedo reticularis, though, that means the pattern is a symptom. It's a sign of another medical condition going on underneath.
And that's the one you really need to worry about.
Well, that's the one you need to investigate thoroughly because those underlying conditions often need specific treatment. Recognizing it could be secondary is vital.
Right. So if it is secondary, what kind of conditions are we talking about? What are the root causes, the etiology?
Okay, so the list of secondary causes is quite varied. And for exams, you really need to know the common important ones. While primary, the idiopathic type with no known cause is probably the most common type overall. The real clinical significance comes from those secondary causes.
And the high yield list for revision includes?
Right. Key secondary causes, definitely connective tissue diseases like systemic lupus erythematosus, SLE. That's a classic link.
Lupus.
Then vasculitis, inflammation of blood vessels, particularly polyarteritis nodosa or PAN. Conditions affecting blood clotting, like antiphospholipid syndrome, APS, that's another really important one.
APS, right.
And then there are others, maybe less common, but still notable, like cryoglobulinaemia, Ehlers-Danlos syndrome, homocystinuria. It's quite a list.
Definitely a list to remember. Linking that skin pattern to these specific diseases. And I guess that list pretty much tells you the risk factors, too.
Exactly right. The risk factors for Livedo reticularis are mostly the risk factors for those underlying conditions. So if someone has a history, personal or family, of autoimmune disease, connective tissue disorders, clotting problems, vasculitis, those are big risk factors.
Makes sense.
Also, certain medications or even things like cold exposure in some contexts can be linked to secondary forms. If you see Livedo reticularis in someone who's had, say, multiple miscarriages or blood clots.
You think APS straight away?
Antiphospholipid syndrome should be very high on your list, yes. It connects the dots.
Okay, this is where it gets really interesting, understanding the why beyond just constriction. Let's dig a bit deeper into the pathophysiology. How does the underlying disease, in secondary cases, actually cause that blood vessel problem?
Good question. So the basic mechanism is still that arteriolar constriction leading to sluggish flow and that visible deoxygenation. But why the vessels constrict or the flow gets disrupted, that varies. In primary Livedo reticularis, it might just be a functional thing. Maybe the autonomic nerves controlling the vessel tone are a bit dysregulated.
But in the secondary ones?
In secondary cases, the underlying disease is actively interfering. For example, in vasculitis, like PAN, you get inflammation that directly damages the vessel walls. That damage can cause narrowing or even blockages.
Okay.
In antiphospholipid syndrome, those autoantibodies make the blood sticky, prone to clotting. Tiny clots can form in these skin vessels, blocking flow.
Ah, actual clots.
Yeah. Or in cryoglobulinaemia, abnormal proteins clump up in the cold and physically block the vessels. In lupus, you might get immune complexes depositing in the vessels, causing inflammation and disrupting flow.
So lots of different ways to get to the same result.
Pretty much. The visual effect, that net pattern from sluggish deoxygenated blood, looks similar, but the process causing it is tied to the specific underlying disease. It all comes back to messing up the flow in that branching network.
Got it. So you see this net-like pattern. What else might it be? What are the main differential diagnoses to keep in mind?
Crucial point for exams and practice. You need to be able to distinguish Livedo reticularis from a few other things. Key differentials would be cutis marmorata, acrocyanosis, Lovedoid vasculopathy, and maybe embolic phenomena.
Any quick ways to tell them apart? Pointers.
Yeah, there are features to look for, though sometimes it needs more investigation. Cutis marmorata, that's often physiological, really common in babies, and it's usually transient. It vanishes quickly when the skin warms up.
Right. Livedo reticularis is more persistent.
Generally, yes. It improves with warmth, but often doesn't disappear completely. Acrocyanosis is different. Again, that's more persistent. Symmetrical blueness, usually just hands and feet, also worse in cold. But it lacks that distinct, widespread net pattern.
Okay.
Lovedoid vasculopathy often comes with painful ulcers, which Livedo reticularis itself doesn't usually cause, and embolic phenomena. That's usually sudden, localized, painful color changes, much more acute than the diffuse pattern of LR. So think transient versus persistent, location, net pattern versus just blue, ulcers or not, sudden onset versus gradual.
That helps clarify things. Now, what about epidemiology? How common is this, and who tends to get it?
Well, the exact prevalence, like here in the UK, isn't really known. It can show up at any age, really, from infants, though, that's often cutis marmorata, right up to older adults.
Okay.
But secondary Livedo reticularis, the one linked to other diseases, that's more typically seen in adults. And its prevalence depends entirely on how common those underlying causes are.
Right.
And importantly, like many autoimmune conditions, secondary LR linked to diseases like lupus is seen more often in women. So age and sex can sometimes give you a clue pointing towards those autoimmune possibilities.
And let's just loop back to the clinical features one more time. To really nail down what you see and what might come with it, the hallmark signs.
The absolute hallmark, as we've said, is that distinctive, persistent, mottled or net-like pattern, purplish or reddish blue, most often on the limbs, arms, legs, sometimes hands and feet.
And it definitely gets worse with cold.
Characteristically worse with cold, yes. And it might fade a bit with warming, but usually the pattern stays somewhat visible, unlike that transient cutis marmorata.
Are there other symptoms that go along with it? Pain, itching?
This is a really key point. Livedo reticularis itself is mainly a skin sign, a physical finding. It doesn't inherently cause pain or itch or anything like that. But if it's secondary Livedo reticularis, the person will often have other symptoms of the underlying condition.
Ah, okay.
So things like joint pain, maybe fatigue, like an SLE, or systemic stuff like fever, weight loss, maybe with vasculitis, symptoms of poor circulation or clotting if it's APS. So if someone has the skin pattern plus other significant symptom.
Red flag for a secondary cause.
Absolutely. Your suspicion for an underlying systemic cause should go way up.
Okay, so you see the pattern, you take the history, maybe there are other symptoms, you suspect it could be secondary. How do you investigate? How do you find that cause?
Right. The investigation isn't really for the Livedo reticularis itself. It's using LR as a clue to hunt for the underlying problem. So it needs a pretty comprehensive evaluation tailored to what you suspect based on everything else.
What are the main steps? Tests.
Always starts with a really detailed history, asking about all those systemic symptoms, autoimmune features, clotting history, family history, and a thorough physical exam looking for other signs.
Okay.
Then you move to tests. Labs are fundamental. You'll likely do a full blood count looking for anemia, low platelets maybe, coagulation profile screening for clotting issues, and crucially, autoantibody testing if you're thinking autoimmune.
Like ANA.
Exactly. ANA is a common starting point. If that's positive, you might go for more specific ones like anti-dsDNA or anti-millisemmum for lupus, depending on the picture. You'd also check inflammatory markers, ESR, CRP, which can be up in vasculitis or autoimmune diseases.
So the tests depend on the symptoms and history again.
Totally guided by the clinical picture. You might also consider imaging, maybe a Doppler ultrasound to check blood flow if you suspect clots, or even angiography in rare cases if you're thinking about larger vessel vasculitis.
And biopsy.
Sometimes, yes. A skin biopsy can be really helpful. It lets the pathologist look directly at the small blood vessels in the skin. They can see inflammation, vasculitis, tiny clots, maybe deposits related to cryoglobulins. It helps confirm what's going on at the vessel level.
Let's try a quick revision scenario. Say a 35-year-old woman comes in. She has this Livedo reticularis pattern. You ask more, and she mentions recurring joint pain. She's tired all the time and gets rashes in the sun.
Yeah.
Based on that age, sex, skin pattern, symptoms, what investigations jump to mind first?
Okay, yeah, that picture screams possible connective tissue disease, especially lupus, SLE. So top of the list would be those autoimmune blood tests. ANA definitely, probably anti-dsDNA, maybe anti-ESISM. Also check inflammatory markers like ESR, CRP, full blood count for anemia or low platelets. And you'd want to check kidney function too, as lupus often affects the kidneys. It shows how the whole picture points you towards specific tests.
That really helps clarify it. So you've done the workup. You know if it's primary or secondary. What's the management plan?
It completely depends on that primary versus secondary distinction. If it's primary Livedo reticularis, no underlying cause found, no other symptoms, then generally it's about reassurance.
Nothing needs to be done medically.
Usually not. It's considered benign, cosmetic. The main advice is practical. Protect the skin from cold, keep warm, as that can make it less noticeable.
And if it's secondary?
If it's secondary, the whole focus shifts. You absolutely must treat the underlying condition. You're not treating the skin pattern directly. You're treating the disease causing it.
Does the meds depend on the disease?
Yeah. Exactly. If it's lupus or vasculitis, you'll be looking at immunosuppressants, maybe steroids, other disease-modifying drugs. If it's antiphospholipid syndrome causing it, then the treatment is anticoagulation to prevent clots. It's all about tackling the root cause.
Does treating the cause make the Livedo pattern go away?
Often, yes. Treating the underlying disease can lead to a big improvement. Sometimes it resolves completely, but not always. Sometimes the pattern can persist even if the disease is under control. So symptomatic advice, keeping warm, avoiding cold, moisturizing, that's still helpful, and regular follow-up is key to monitor the underlying condition.
Another quick scenario then. Patient gets diagnosed with Livedo reticularis. Workup confirms it's secondary to antiphospholipid syndrome. They have the antibodies, maybe a history of clots. Based on what you just said, what's the absolute cornerstone medication you'd expect them to be on?
For antiphospholipid syndrome, without a doubt, it's anticoagulation. You'd fully expect that patient to be on warfarin, or perhaps one of the newer direct oral anticoagulants. That's to prevent those dangerous blood clots, the main risk in APS. That link, LR plus APS equals anticoagulation, is super high yield.
Got it. Great connection. Lastly then, prognosis. What's the outlook, and what complications should we be aware of?
Okay, prognosis, just like management, hinges on the type. Primary Livedo reticularis, generally excellent prognosis. It's benign, doesn't progress, doesn't usually cause complications itself. It's more of a cosmetic nuisance that might stick around.
And secondary?
For secondary LR, the prognosis is tied entirely to the underlying cause. How severe is it? How well can it be treated? If you catch the underlying disease early and manage it effectively, the outlook is much better. The Livedo might improve, but the overall prognosis depends on controlling that systemic disease.
And complications, do they come from the skin pattern itself?
Almost entirely no. The serious complications linked with Livedo reticularis come from the underlying conditions causing the secondary form.
Such as?
Well, uncontrolled autoimmune diseases or vasculitis can damage organs, kidneys, heart, lungs, brain. Clotting disorders like APS carry that significant risk of major clot stroke, DVT, PE.
I thought I recalled something about Livedo reticularis itself being linked, maybe rarely, to clot risk.
Ah, yes. It's worth mentioning, but keep it in context. There is some suggestion, yeah, that very persistent Livedo reticularis might, rarely, indicate a slightly higher tendency for tiny clots in the skin vessels. But the overwhelming risk of serious clots comes when LR is a symptom of a known underlying clotting disorder like APS.
So focus on the underlying cause for risk.
Definitely. Managing the underlying condition is the key way to cut down the risk of serious complications.
Okay, so let's wrap this deep dive up. Livedo reticularis, that cold-sensitive, net-like purplish skin pattern. The absolute key takeaway for exams and practice is distinguishing primary, which is generally benign, from secondary, because secondary LR acts like a potential signpost, a clue pointing towards a whole range of possibly serious underlying issues: autoimmune diseases, vasculitis, clotting disorders.
Precisely. Recognizing the pattern is step one. Step two is knowing it could mean something systemic is going on, remembering that high-yield list of secondary causes, and knowing how to investigate based on the whole clinical picture. That's vital for anyone revising for exams like the MSRA.
So what's the big picture here? It really makes you think, doesn't it? How something that just looks like your skin reacting a bit oddly to the cold could actually be the very first sign, that first visible hint of a serious condition affecting the whole body.
Yeah.
It just underlines how the skin can be this amazing window into our overall health.
It really can. A powerful reminder.
For more free MSRA revision resources, do visit freemsra.com, and for the full premium revision toolkit, you can head over to pastthemsra.com.